Hi there, my name is Felicia Miranda, and I will be presenting my assigned case study in this short video. Before I introduce my patient to my listeners, I would like to inform them of the condition and the disease that was assigned my patient. The disease is Addison's, which is an adrenal hormone insufficiency. The condition is dysphagia, which is difficulty in swallowing. That being said, my patient is Marisol Perez. She is 43 years old. She is Hispanic. She suffers from malnutrition. I would like to focus in on this and say that because she has dysphagia, her physician probably would advise her to use a feeding tube. Feeding tubes are uncomfortable, and the probability of her actually using it would be 0. So because it hurts her so much to swallow, she probably won't be eating a lot of food or definitely not eating healthy food, which will cause her to have malnutrition. My patient is also single. And lastly, I would like to focus in on her picture. If you see her face, she has hyperpigmentation. This is a side effect of one of the medications that you will see on the next slide. The medication that my patient will be taking is hydrocortisone, and its brand name is Cortef. Now, these are tablets that she will be taking daily, 2 to 3 times a day, 15 milligrams to 25 milligrams, and this is for an adrenal insufficiency and any adrenal insufficiency attacks. Special conditions are to take the highest dose during the morning. Contraindications are obviously hypersensitivity to hydrocortisol and systemic fungal infections. Oral effects are xerostomia and, as I mentioned earlier, hyperpigmentation of the gingiva or the face. For her condition, which is dysphagia, I researched and there was no specific medication to take for dysphagia, so I put none available. I would like to inform my listeners that my patient was assigned ADA case type 2 with localized ADA case type 3. Now, if we look at her chart, you can see probing depths ranging from 3 to 4 millimeters, from teeth number 4 to 15 and number 29 to 18. 1, 32, 17, and 16 are missing. We can see bleeding on probing throughout the whole dentition. We also see slight cal, and we also see that on the left side you have your localized ADA type 3, which is moderate periodontitis. And you can see, remember, that 5 to 6 millimeters is what is considered ADA type 3. So on teeth number 2, 3, 31, and 30, we can see these probing depths. We can see this bleeding. We can see this cal loss. So those 4 teeth right there are my localized moderate periodontitis. We have now reached the periodontal classification slide. For gingival disease, I selected non-plaque induced based off the fact that my patient has Addison's disease, is taking a medication, and suffers from malnutrition. For periodontitis, I put generalized because she has generalized mild periodontitis. Slight, 1 to 2 millimeters, cal. For periosystemic disease, I selected systemic autoimmune disease, once again referring to Addison's. I did not select dermatological disorder even though my patient has hyperpigmentation Because hyperpigmentation is a side effect of the medication, it is not a disorder in itself. Lastly but not least, for periodeformity or condition, I have listed furcation class 1 on tooth number 3. Now if you go back to my periodontal charting on on tooth number 3, the facial, I have charted furcation 1 because this is a sign of ADA case type 3, having a class 1 furcation. So on this slide, I am just reiterating my case type, which is class 2 ADA generalized. 28 out of 32 teeth have mild periodontitis, which is 88% generalized mild periodontitis. Probing depths are 3 to 4 millimeters. We see bleeding. We have recession. On our radiographs, we will see that we have alveolar bone 2 to 3 millimeters below CEJ, horizontal bone loss, 1 to 2 millimeters cal, slight loss of interdental septum, and up to a 15% radiographic bone loss. Now, for localized ADA case type 3, I wrote that the teeth that are affected by this are 2, 3, 30, and 31, which is once again seen in my probing chart. Probing depths are 5 to 6 millimeters. We have recession, we have bleeding, we have furcation class 1 on tooth number 3. And I do not have any radiographs that show this localized ADA case type 3. This is the picture that I have selected to represent my ADA case type. I would like to state that I understand it is minimized, so it's very difficult to notice all these descriptors, but I selected it to be one of my gingival images. It is actually my number 4 gingival image, so if it is hard to notice these descriptors, you can always head over to that slide and you will see an enlarged version of this picture. That being said, I would like to go ahead and quickly describe all these descriptors. For gingival color, it appears generalized, moderate, dark, pink, bright red, with distribution from attached gingiva to papillary. Gingival contour appears generalized, moderately rolled, and rounded margins, with initial signs of recession. Papilla is slightly bulbous. Consistency appears moderately soft/spongy, involving attached and free gingiva. Surface texture appears localized, slightly shiny, with stippling on free gingiva. On this slide, we have all our assessment statements narrowed down and put together. I would like to read out the AAP classification and the ADA case type because I have not done so yet. So for my AAP classification, my patient presents with non-plaque-induced gingival disease due to infection caused by systemic disease, medication, and malnutrition. Patient has generalized chronic periodontitis associated with slight clinical attachment loss on 15, 18, 19, and 20. Patient also has class 1 furcation on 3. For my ADA case type, it says, patient presents with generalized mild periodontitis with pocket depths ranging 3 to 4 millimeters, bleeding, and slight recession throughout the dentition. Localized signs of moderate periodontitis on 2, 3, 30, 31, with pocket depths ranging 5 to 6 millimeters, bleeding, and recession. The presence of class 1 furcation on facial of tooth number 3. Now, this is the first time we have seen a picture of my radiograph. This strongly and beautifully shows ADA class type 2. Here we see radiographic findings support evidence of horizontal alveolar bone loss, 2 to 3 millimeters below the CEJ, 1 to 2 millimeters of clinical attachment loss. Slight loss of interdental septum is visible with up to 15% overall radiographic bone loss. I will not be reading gingival descriptive statement because I just read it in the gingival description table. Here we have an enlargement of my radiographic image. We can see generalized horizontal bone loss with 2 to 3 millimeters below the CEJ. There at the bottom we can see the loss of the interdental septum, which is a sign of ADA class type 2. Underneath that we can see initial class 1 frication, which is also a sign of ADA class 2. For my first gingival image, we can see that the texture is generalized stippling, consistency is shiny and spongy. In my gingival image number 2, we have that the color is generalized hyperpigmentation. If you can see, every single gingival image that I have selected has hyperpigmentation in it because that is a side effect of the medication my patient is taking. For my gingival image number 3, I have stated that the color is once again generalized hyperpigmentation. The margins are slightly cratered. The consistency is bulbous. And lastly, for my gingival image number 4, this is the official picture that was selected for my ADA class type 2 presentation. Now you can see that the texture is shiny and spongy, consistency is rolled and rounded, and once again you can use this slide to compare the gingival descriptors that you might have not seen so well on the minimized version in my gingival descriptive table. Let's talk diagnosis now that we have viewed the condition and the state that the teeth and gingiva of my patient are in. We can have accurate therapeutic goals. Prognosis is good. Rationale, due to the lack of severity, based on patient compliance on the final outcome will be better determined. The outcome, while with patient compliance to OHI, cal can be regained, bone loss can be arrested, and bleeding gingiva will be eliminated. Modifiable risk factors, caries risk, nutritional counseling, home care instructions, and improvement with serostomia. Non-modifiable risk factors are the condition that my patient possesses, which is dysphagia, and the medications used to treat Addison's disease. For short-term therapeutic goals, I stated that we could arrest the inflammation, stop bleeding of the gingiva, apply fluoride to prevent formations of caries, and after her cleaning, she could take saltwater rinses to heal her gingiva. For long term, I stated thorough home care, reattachment of gingiva, no new carious lesions, nutritional analysis, and frequent dental visits, that being a 3-month recall. We have now reached the treatment planning, and on this slide I have highlighted all the codes that I will be using. I will proceed to the next slide to explain them more in depth. For my treatment plan, I started out with an exam, D0150 Comprehensive Initial Evaluation, which includes periodontal screening. For treatment, I have selected the code D4342, which is an SRP code that involves 1 to 3 teeth in a quad. I put times 4 because I will be using this code 4 times for each quad that I will be cleaning. My patient has periodontitis. They have mild and moderate periodontitis, but they generally have periodontitis. So I have selected an SRP treatment in all 4 quads. I also have selected the code D4910, which is the periodontal maintenance code, because when I have finished the last SRP quad, I will have my patient come back in 2 weeks and I will give them a perio main to see the difference that my cleaning has done and to see if they have regained any attachment. For prevention, I selected code D1205, which is topical fluoride. I am not sure if this code is being used still. If I remember right, I think we said that it's not. But the point of selecting this code is because I want to give my patient fluoride at the end of their treatment. Fluoride, because one of their side effects of their medication is xerostomia, and with xerostomia, we have caries risk. For miscellaneous procedures, I selected D1330, which is OHI, and also D1310, which is nutritional analysis. For instrument selection, I have selected for Gracie's standards, after 5, mini 5. The shank would be standard and rigid. My rationale for this is light to moderate calculus removal and long shanks are appropriate for SRP. For scalers, I selected Nevi, also selecting standard and rigid for shank rigidity. My rationale for this is removal of any possible tenacious calculus. And certain Nevis, if I remember correctly, Nevi 3 and 4, are effective in interproximal and in tight contacts. For ultrasonic inserts, I have selected Powerline 1000 and Slimline 1000. My rationale for this is I have experience with a 3-bend shank, and I know that for me and my patients, I am effective in removing calculus with this 3-bend shank. I would start out with Powerline and get the initial calculus off, and then I would go in with my Slimline 1000 because it has a slimmer tip, so it would get off any of that fine burnish calculus I had left behind. For home care recommendations, I have selected a few, starting with fluoride gel and chlorhexidine. Fluoride to help prevention of caries, chlorhexidine with the healing process after treatment. OTC dental aids are floss and biotin. Biotin for xerostomia. Toothbrushing, the technique I have selected is the fast technique if my patient uses a manual toothbrush. I always like to advise my patients to use electric Oral-B. If my patient decides they do not want to use electric Oral-B toothbrush, I always advise them to use soft bristles if they are going to buy a manual toothbrush. Special instructions are to brush your teeth 3 times a day for 2 minutes at a time. Toothpaste selection is Colgate Total. Special instructions for this is if there are any allergic reactions, change toothpaste immediately. Floss and flossing aids. For type, I have selected a water flosser. I always like to give this option to my patients, My favorite floss is Glide Oral B. Special instructions: floss every day and remember to use the C shape when flossing. Interdental aids, type would be gum stimulator. Special instructions is to massage the gingiva gently. For mouth rinses, I would use Listerine Zero, specifically Zero because it is alcohol-free. Anything that is alcohol-free is great recommendation for patients who suffer from xerostomia because alcohol will make the mouth more dry. Special instructions is swish only 30 seconds. I explain to all of my patients that swishing more than 30 seconds kills good bacteria. But swishing exactly 30 seconds, you have successfully killed the bad bacteria, but not have damaged the good bacteria. With fluoride, once again, I have mentioned it, special instructions, you place a ribbon of fluoride gel on the tray, set the tray on the teeth, gently bite for several minutes to distribute the gel between the teeth, and leave the tray in for 5 to 10 minutes. Do not rinse, eat, brush for 30 minutes. Products to avoid, once again, any mouthwash or anything that contains alcohol. Reasonings are concerning xerostomia. For my nutritional analysis slide, we have the synopsis of my patient's conditions, which is Addison's disease. Once again, it is an endocrine disorder in which the body fails to produce sufficient amount of hormones that are produced by the adrenal glands. Foods to increase: cheese, milk, eggs, and fish. Foods to decrease: anything with high sugar. Dysphagia is once again difficulty in swallowing. Now I want to stop at this moment and describe the reasons why I have selected these foods. Corticosteroid treatment is linked with osteoporosis, and my patient is taking a corticosteroid, which is hydrocortisone. So my patient is at risk of osteoporosis. The way to treat that is consuming calcium and vitamin D. And eggs, cheese, milk all have vitamin D. Also, with Addison's disease, one of the most common hormones that is not produced enough is aldosterone. Now, aldosterone helps regulate blood pressure as well as water and salt balance in the body by helping the kidneys retain sodium and expel potassium. If we don't have enough aldosterone in the body, then we need to have a high intake of sodium. Not too high that it raises the blood pressure, but high enough. And we can do that by having, like I said, a rich sodium diet. Also, I wanted to mention for my supplements, I have that vitamin B is one of them. That is because one of the biggest symptoms, if not the most common symptom of Addison's disease, is fatigue/stress. So, vitamin B helps the body deal with that and stimulates the production of the correct body chemicals. And vitamin B is found in cheese, eggs, fish. Also, I also added zinc as another supplement because zinc helps counteract stress too. Some zinc food-related products could be seeds, nuts, sea fish, spinach, and mushrooms. These are some conditions to take into consideration for a person that has Addison's disease. So, going back to my slide, adding to diet, I'm increasing my vitamin intake by eating more vegetables and fruits. Examples are listed. To omit from my diet, I want to decrease candy, soda, tomato sauce and ketchup, sport drinks, chocolate. All these items that I have just listed have a high sugar intake. Not good for reducing caries risk in my patient. What I want to avoid from my diet? Alcohol, which I have mentioned already, and high fat foods, which I have mentioned already. And for my supplements, I have already mentioned why I would be taking vitamin D for osteoporosis, vitamin D for stress, sodium for insufficient aldosterone hormone, and zinc also for fatigue/stress.